Hello, my name is Siddharth and topic is ultrasound guided erector spinae block. The erector spinae comprises a group of muscles including the iliacostalis, longissimus, and spinalis muscles. They run bilaterally from the skull to the pelvis and sacral region, and from the spinous to the transverse processes, extending to the ribs. The muscles change their size and profile during their craniocaudal course alongside the spine. See the back muscles, trapezius, rhomboids, etc. Sensory innervation of the upper posterior thorax arises from the dorsal rami of the first cervical, C1, through the fifth lumbar, L5, nerves, while the ventral rami of the thoracic spinal nerves from T1-T12 continue as intercostal nerves innervating the interolateral chest and abdominal wall. At T5-7 level, muscles layer are trapezius, rhomboid major and erector spinae are seen above to transverse process. But, at T8-10 level, muscles above to transverse process are trapezius and erector spinae. In 2016, first described by Mauricio Foro and others for thoracic neuropathic pain, they used 20 ml 0.5% ropivacaine at T5 and got sensory level T3-T9. Later on, reported study or case reports showing analgesic efficacy of erector spinae block are for ventral hernia repair. Hamilton and others used it for rib fractures. For postoperative analgesia in pediatric oncological thoracic surgery. Again Foro and others for SQ analgesia in thoracotomy after epidural failure. Then for visceral abdominal analgesia in bariatric surgery. Then for video-assisted thoracoscopic lobectomy. For breast reconstructive surgery. Post-op analgesia for total hip arthroplasty at L4 level. For chronic shoulder pain. For major open abdominal surgery. For pulmonary malignancy. For pediatric nephrectomy. For carotid endarterectomy. For radical retropubic prostatectomy. Based on above evidence, we can use this block at various level for various indication like at T2, T5, T8 and L3. The usual ultrasound setting, a high frequency linear probe, in muscle preset, resolution mode, depth 4 cm, 5 cm short bevel needle within plane approach using 20 ml local anesthetics. Patient can be positioned sitting, lateral or prone position. After selecting the target transverse process for the block, place the transducer in a perimedian sagittal orientation, approximately 2 cm away from the midline, spinous processes, and try to visualize the transverse process. With the transducer placed in a perimedian sagittal orientation at the level of T5, the trapezius, rhomboid, and erector spinae muscles appear as longitudinal hypoechoic structure superficial to the transverse processes that are visualized like squared hyperechoic rims with an acoustic shadow behind. At higher thoracic levels, for instance, above T5, trapezius, rhomboid major and erector spinae muscles can be identified as 3 layers superficial to the transverse processes. In the lower and mid-thoracic levels, only trapezius and erector spinae muscles can be seen. C. Rib appears as round, superficial hyperechoic structure, while transverse process appears as square deep hyperechoic structure. In this approach, probe is placed transversely 3 cm lateral to spinous process to scan transverse process. C. From midline to lateral, spinous process, lamina, transverse process and rib are visualized. Let's see screening video. Now, let's see real block video at T5 level with out of plane technique. Let's see block video 2. Here patient was obese and block was done at L1 with curvilinear probe. Clinical pearls. It is a new fascial plane block which is simple, safe and having multiple indications. Continuous catheter technique can be used to allow redosing. There should be cephalad caudal linear fluid spread during block on ultrasonography. One should use curvilinear probe in obese, and when depth to transverse process exceeds 4 cm. Evidence number 1. In 2016. First described by Mauricio Foro and others for thoracic neuropathic pain. They used 20 ml 0.5% ropivacaine at T5 and got sensor level T3 T9. 4. And others reported that the local anesthetic spread involved both the ventral and dorsal rami of spinal nerves. Evidence number 2. Anna Schwartzman and others did MRI study to find out mechanism of erector spinae block. They found one single injection retrolaminar and ESP blocks in fresh cadavers both produce epidural and neural foraminal spread and thus can be expected to have clinical effects similar to thoracic paravertebral blockade. The ESP block exhibits additional intercostal spread that may contribute to wider analgesic coverage than the retrolaminar block. At Hickory and others did MRI and anatomical study to compare erector spinae block and retrolaminar block. They found one single injection retrolaminar and ESP blocks in fresh cadavers both produce epidural and neural foraminal spread and thus can be expected to have clinical effects similar to thoracic paravertebral blockade. The ESP block exhibits additional intercostal spread that may contribute to wider analgesic coverage than the retrolaminar block. Evidence number 4. Tsushima and Hiroshi did study of spread of local drugs in erector spinae block and found it can block the thoracic spinal nerves and the sympathetic nerve fibers. Mechanism of sympathetic block is unknown. Drugs may spread to the paravertebral space. Evidence number 5. Jason Ivanuzik and others did a cadaveric study investigating the mechanism of action of erector spinae block. They found that there was no spread of dye anteriorly to the paravertebral space to involve origins of the ventral and dorsal branches of the thoracic spinal nerves. Dorsal ramus involvement was posterior to the costotransverse foramen. To sum up, many controversial results as above can be found in the literature. But still, this block has found to be effective in a wide range of indications both in pediatric and adult patients. As we all know that unrelieved acute pain could lead to chronic pain, this block should be used as a part of the multimodal analgesia methods. Thank you very much for your kind attention.